All right, I'd like to introduce our speaker today. We're very, very pleased to have Grace Marie Turner here with us. Grace Marie spoke for us before in Rome at a health conference we had there, and she's a very good speaker and really knows the issue of healthcare, so we're very pleased and delighted that she was able to join us here in Grand Rapids. And another thing is, she told me that she actually worked on the Ford campaign many years ago, so this morning she went to the Ford Museum and was looking for herself. No, that's not true. I made that up. But she is the president and founder of the Galen Institute, which is a public policy research organization that she founded in 1995 to look at and promote informed debate over free market ideas for health reform. She's been instrumental in developing and promoting ideas for reform and the transfer of power over healthcare decisions to doctors and to patients. One thing she advocates is a consumer and customer and patient-based or driven healthcare. She speaks all over the world and all over the United States, especially on these issues. She's a member of the National Advisory Council of Healthcare Research and Quality. She was on the Medicaid Commission. She's, as I said, spoken at the London School of Economics, Oxford University, the Gregorian University in Rome. She testifies regularly before Congress, advises the White House and other senior administration officials, governors, and state legislatures on health policy. She's the founder and facilitator of the Health Policy Consensus Group, which is a forum for analysts for market-oriented think tanks around the country. She's the editor of Empowering Healthcare Consumers Through Tax Reform, and she produces a widely read electronic newsletter, Health Policy Matters. I think if you want to sign up for that, there are ways to do that there in the back. She has been published in the Wall Street Journal, USA Today. She's been on 2020 and hundreds of radio and television programs across the United States. In the 90s, she was the executive director of the National Commission on Economic Growth and Tax Reform, and for 12 years, she was the president of Arnett and Company, a health policy analysis and communications firm. All right, so we're very, there's so many things. I mean, we're very pleased, delighted to have Grace Marie. So please, I'd like to welcome Grace Marie Turner.
Thank you, Michael. You're the best. Thank you. Good afternoon, everybody. So the microphone works okay? Everybody in the way back can hear? This is great. Wonderful. I brought my BlackBerry. This is the first time I've ever going to read you something from my BlackBerry. I got an email message yesterday that's very relevant to today's talk. So it'll be the first time I ever did that. So I'm not up here because I'm expecting a phone call. It's really a pleasure to be here in Grand Rapids and to be a guest of the Acton Institute. I have admired the work of this organization for a long time, but the closer I get to it and the more people I meet in this organization, the more impressed I am. It really has a unique place in the public policy debate and is playing a very important role in helping to educate people about valued-based conservative principles and where we as a country get the values that I believe have made the United States the great country that it is and the world leader that it is. And the Acton Institute is not only a leader in this country but increasingly internationally. And I was really privileged to have participated in the Acton Institute's conference that they jointly sponsored with the Pontifical Healthcare Council at the Vatican at the Gregorian University, which I'm now told is the Greg in Rome. And it was a pleasure to meet Michael there and Chris and Father Sirocco. And thank you all for the chance to talk with you today. And I have to tell you, I am particularly impressed that so many of you would come to a forum talking about healthcare. So many people think, oh my goodness, it's so complicated, I can't possibly ever understand it. It's too hard, it's too complex. And many people, and especially Republicans in Congress, say it's just not our issue, it's the other side's issue. It's really our issue. And we'll talk today about why some of the conservative and Christian values that really underlie healthcare can, I believe, let us take ownership of this issue and move forward. Just a little bit about the Galen Institute. I found the Galen Institute in 1995. We're a nonprofit, free market research organization. You're familiar with the Heritage Foundation and the American Enterprise Institute, the Cato Institute, and others that do public policy research on a wide variety of issues. We focus just on healthcare, but we do all the same things they do. We do conferences and papers and speeches and frequently have forums on Capitol Hill around the country. And I do a weekly newsletter called Health Policy Matters. It's free electronic newsletter to help people stay tuned to what's happening in the free market health policy conversation. And I would be more than happy to add any of you to our distribution list. It's widely read in the administration, members of Congress, state houses, reporters. It's just send me an email at gracemarie@galen.org or give me your card afterwards, or go to our website, galen.org, and there's a little box at the top that you can sign up for the newsletter. But I'd love for you to be continuing part of this conversation. A little bit about the sort of the overview of what I want to talk with you about. I thought I would give you an overview of some of the things that I said during my talk in Rome, and then how that relates to the current debate over healthcare and some of the issues that are really at the center of the debate in 2008, and I do think this is going to be a particularly important year for healthcare. In 1992, when President Clinton was elected, he was elected with a mandate to give the country universal coverage. We were all going to get free healthcare. There really weren't very many more details than that offered in the 1992 campaign. And we all know that once we learned the details of the 1,341 pages of legislation that the White House sent up to the Congress for consideration, that the American people balked. And they said, that's not what we had in mind. So now, 15, 16 years later, I think we're going to go at this again. And the American people are asking more detailed questions, but we still have a fundamental question. And that is, who's going to be in charge of decisions? Is it going to be individuals and their families based upon our own value systems and what we consider to be important? Or is it going to be government playing the role of the broker to make sure that everybody is treated fairly and equitably? That was the question in 1992, and I think it's going to be the question again in 2008. And you know, there really are a lot of people who believe that the government should play a crucial role in organizing our health sector. They believe that if healthcare is going to be delivered fairly and equitably, that we have to have a central force and a central agency making those decisions, government. Others believe healthcare decisions are just too complex for individuals to make on their own, that it's too hard and we need to have experts making decisions about what kind of treatments we should or should not have. And others say that the new technologies that are here and new technologies that are coming are so expensive and so complex that we need to have somebody making a fair decision about access to those technologies and how people that invent them are going to be paid, to make sure that people are not profiting excessively from healthcare. You know, we do have private, for-profit healthcare in the United States delivered through hospitals, physicians' offices, pharmacies, clinics, laboratories, and the whole concept of competition, I think, really does get to providing more options for people and more options that are innovative, new treatments and new therapies. But a lot of people really push against that. And there's actually a whole campaign in the state of California to completely do away with for-profit healthcare. One step toward, how are we doing with the sound there? Okay? I don't want to get too loud. For-profit healthcare that they say is just evil. Nobody should make a profit off sick people. When I speak in Europe, there are people who believe that our for-profit health sector is really the root of many of the problems that the world sees in our health sector. They believe that the 47 million people that we have in this country without health insurance, which is a significant problem and does need to be solved, and there are ways to solve that with free market ideas as well as through government mandates. But when I speak in Europe, I talk about this multi-faceted system that's half public and half private in our country, and tell them about the 47 million people. They think that we have a permanent underclass of 47 million people who have no access to the healthcare system whatsoever, and it's the same 47 million people. Now, we all know if that were true, it would be a national scandal. But the number of uninsured it's a flowing number of people. People are in and out of the healthcare system frequently. About half of the uninsured are uninsured for 4 to 6 months because they're between jobs. Since we tie health care to the workplace in this country, which no other major country does, by the way, people lose their health insurance when they lose or change their jobs. We don't think about that as a problem, but it's something that we can also solve with public policy. But it is one of the main reasons that we have so many people without health insurance, because they're flowing through the system of employment-based health insurance. 80% of the uninsured are working or are dependents of workers. So people who are very poor are almost always going to be eligible for Medicaid or other state and federally supported programs. But the logo of the Galen Institute, if I had a PowerPoint, I would show you sort of our view of where the problem is in our health sector. That if you think of sort of an upside down bell curve, a little shifted to the left, if people are uninsured, oh, you have it in front of you. Great. Thank you, Michael. See the logo at the top, Galen Institute? Okay, think of the vertical axis as the likelihood that you're going to have health insurance, right there on top. And then the horizontal axis as income. And the poorer you are, this is for people under 65, the more likely you are to be eligible for Medicaid. Not in every state. In some states you don't fit into the right categories. But in most cases, the poorer you are, the more likely you are to have access to Medicaid. Then you fall into this dip where the G is, which I call the Galen gap, where the great majority of the uninsured are before people pick up both the higher incomes and the better paying jobs that are more likely to come with health insurance. So this trough is where the problem is. This is where the great majority of the uninsured are. And we have two ways we can solve this. Either we can move that curve from the left by expanding government programs, or we can move it from the right by providing more of the same kinds of incentives for private insurance that the great majority of Americans have. So if you sort of think of that as actually, I have a big poster of this, and members of Congress used my poster in floor debate in the U.S. House of Representatives a couple of years ago to try to help their colleagues understand that the uninsured, who the uninsured are, and that we need to solve this problem with a really targeted solution that doesn't disrupt care for everybody else. The others in Europe also are surprised to learn that in the United States, we spent $2.2 trillion on health care this year. Almost half of it, 45%, is spent through government programs. Medicaid, Medicare, the state children's health insurance program, and the other half privately, primarily through job-based health insurance, but also out-of-pocket costs and direct payment for health care, which is still legal in the United States, unlike Canada. So people are also surprised to learn that we spend more on government-run programs in healthcare in the United States as a percentage of our gross domestic product than other countries that have so-called universal coverage spend in total. And our government programs cover 1/3 of our population. So we spend more, we spend as much just on the 1/3 of the country covered by Medicare, Medicaid, and the state children's health insurance program than the UK, for example, spends on health care for everybody. And what that means is that we also are paying for the uninsured, maybe indirectly, because as we all know, even if we don't have a universal mandate for health insurance in the United States, we do have a mandate that every hospital has to treat somebody if they show up sick. And many people say, well, that's one of the reasons we have so many people without health insurance. People know they don't have to have it because they can get treated in any case. And in some cases, some states, people don't buy health insurance because there's something called guaranteed issue that forces insurance companies to sell insurance even if you wait until you're sick to sign up, which isn't really insurance. So we've done a lot in this country to really create the problem that we've got, especially in a country in which 3 in 10 workers are going to change jobs every year. Tying health insurance to the workplace is extraordinarily problematic, and especially in a growing mobile economy. I talked with someone from the National Restaurant Association not long ago, and they told me, you know, people are telling us that we're going to have to cover all of our workers, that we're going to have a government requirement. That's certainly one of the provisions that all employers must provide coverage to their workers. They said, sometimes we have people who work for us for 3 days. How are we going to spend that entire time filling out paperwork to get them signed up for some health insurance program and then they're gone? The loss of productivity, the complexity of that is just not going to work in our mobile society. So we do have a problem with 47 million uninsured, but we need to put that problem in context and understand who the uninsured are, how can we target solutions to them, and how we can do that in a way that doesn't disrupt and change what I believe is the finest healthcare system in the country. And it's wonderful to see in Grand Rapids the presence of healthcare and health innovation. And I think this is going to continue to, Grand Rapids is already such a wonderful, wonderful city, and I think your presence in the innovation of 21st century medicine is going to be incredibly important, and I really congratulate you for that. So, in the context of the problems that we have, what do we want to do to really move us toward a system that is based upon the same kind of values that govern people's decisions in the rest of this country? And do it in a way that doesn't disrupt the doctor-patient relationship, which really is already disrupted, that doesn't undermine incentives for individuals to take care of themselves, and that also continues to encourage people to reach out through charity and giving of themselves through volunteer efforts. That really is another wonderful pillar and signature of this country. As we look at the presidential candidates and what they're offering, I think it is important to recognize that most of the Democratic presidential candidates, and certainly the leadership in Congress, are offering plans that would move toward a much bigger role for government in our health sector, because they believe that that's how we're going to make this system fair and equitable and affordable. And the Republican candidates, I have a piece there, the GOP's prescription for health care, that was published in the Wall Street Journal when we actually had several candidates in the Republican presidential primary. And one of the reasons that this wasn't much of an issue in the Republican presidential debate is because they pretty much all agreed. Unlike between Senator Clinton and Senator Obama, there's a big dispute we'll get to in a minute, between them, which is why you hear a lot about health care in the Democratic presidential primary. But all the candidates are always trying to distinguish themselves from somebody else, so they have to have something to fight about. And among the Republicans, they didn't. They all believe that we need to move toward a system with much more individual control over insurance, market forces beginning to solve many of the problems, and changing some of the financing systems that are causing the large number of uninsured that we have in the first place. But if you look at what some of the, again, fundamental principles are that we need to pay attention to as we think about healthcare reform. I quoted in my talk in Rome Pope Leo XIII, who observed that state benevolence cannot replace charity. So if you think about a benevolent state, it's, I think, in almost a contrast in terms. And I'll tell you a little story. I testified, as Michael said, I do testify before Congress a lot, increasingly as a minority witness in more ways than one. I testified before the House Energy and Commerce Committee last week. They had 8 or 9 witnesses lined up at the witness table. I was the one sort of representing the taxpayer. The hearing was about a piece of legislation that was going to put a stop to several Medicaid rules that the administration had issued that are designed to stop some of the most egregious waste and fraud in the Medicaid program. Medicaid, again, the program for the poor, low income, jointly funded by states and federal government. And I cited studies from the Office of Inspector General that talked about how this fraud and waste is rampant. I cited studies from the General Accounting Office and sort of really documenting the reason that these rules were needed. Congress wanted to stop them. The rules, by the way, are designed to, at most, cut the rate of increase in Medicaid spending by 1% over the next 5 years. $15 billion out of, would that be 12 billion out of about 1.2 trillion in spending on this program over the next 5 years. 1%. You would have thought they were closing down the program. There was a pediatrician, a nursing home administrator, a school administrator, a hospital administrator, all of them saying that these cuts would absolutely devastate Medicaid for their constituents. Nothing that they said was relevant to what these programs, these rules would actually do. I cited, for example, a GAO report that said that Medicaid funds were being used to take people to restaurants and bingo games. This is a GAO report. There's another report where a nursing home in New York, which is particularly good at gaming Medicaid rules. Most of this would be considered fraud if it were in the private sector, by the way. Government not only allows it, but now you have almost a de facto encouragement of it by Congress not stopping these rules. But a nursing home billed $70 million, had expenses of $70 million over 3 years in taking care of indigent nursing home patients. The state of New York billed the federal government $138 million for that care through gaming the system and rules. And it only gave the nursing home back $50 million. And the nursing home was threatened with losing its accreditation. And I said, I don't see how that's helping patients. If the state is using this to take money out of the system, to pay for roads, to pay for infrastructure, to pay their own share of Medicaid, that's not helping Medicaid patients. I was the one attacked in the hearing, including by some of the Republican members of the committee. The rules and this legislation passed yesterday by unanimous vote. So much for the taxpayer. I was the person defending the taxpayer, and one of the committee members said, well, we haven't gotten any letters from anybody saying that these rules should be allowed to go into effect. I said, You know, most people are living their lives and they're not focused. Did anybody here send a letter to the Community Conference Committee? No. So that's really what happens with government programs. Somebody has a stake in every single penny that's being spent by government, even if it's fraudulent, even if it's not helping the people that it's supposed to help. And it's very difficult to solve it. It was absolutely a stark study in contrast to me. And the only thing that I can see is the importance of not allowing more of our health sector to be taken over by the government, because it will be controlled politically. Each one of these constituencies was a political constituency, even though they weren't representing the taxpayer. So just one little example of how I think the taxpayer is not served by too big of an expansion of government. The state children's health insurance program is another example. That was a huge consternation. And members of Congress were accusing the president of being completely against children by not wanting to expand the state children's health insurance program. What do you call it here? Usually it's S-CHIP. Do you all call it S-CHIP, or is it? Anyway, the program for children whose parents make too much for them to qualify for Medicaid, but don't yet have the good higher paying jobs. New York State, once again, our friend, had wanted to expand the state children's health insurance program up to 400% of poverty. That's $83,000 a year of children on government-run programs. And when the Democrats took over Congress, just by coincidence of timing, this program was up for renewal and reauthorization. And so this Congress was really intent on using this as a platform to expand the opportunity for virtually all parents to put their children on this government S-CHIP program, called different things in different states. And we did some research. Once again, the GAO is our friend. The GAO said, you know, in some states, as many as 87% on the state children's health insurance program are adults. Does that make sense? No, it doesn't make sense. So we pointed out some of these things. I had a couple more pieces in the Wall Street Journal. And finally, when people started to realize that this is a program that should be helping poor children, we began to turn the tide. And the president vetoed this major expansion of the state children's health insurance program. And one of the few things that people began to respond to was that the higher up the income scale you go in allowing states to put children on these government programs, the more likely you are to be crowding out the private coverage that their families already have. So does it make sense, when we have 47 million people without health insurance, to be replacing private coverage with this new public program for kids who already have insurance and who are in middle income and even upper middle income families? So the president vetoed it. And some very brave members of the House, mostly Republicans, but some courageous Democrats, said, you know, you're right. We need to keep this program focused on the populations that should be focused on. So, if you've read all those stories, how awful it was that President Bush was against health insurance for children. He wasn't. He was saying, let's just keep the program focused on the kids who really need it. I had a chance to talk with the governors of Pennsylvania, New Jersey, and Delaware to say, you know, what do you need? Let's sign up the kids who are eligible for this program first, because the great majority of uninsured children are eligible for the state children's health insurance program, but they're not signed up. So would it help them if the government were to expand this to higher income families? Are these kids going to be helped if suddenly the government is focused on enrolling tens of millions more upper income children? It's not going to help them. And I said, what do you need to do a better job of enrolling these lower income children who already are eligible but not enrolled in these programs? And they did not have a good example. They did not have a good answer. They're just hard to reach, they said. Are they going to be harder to reach once their focus is on enrolling kids whose families make $83,000 a year, that's going to be easy. They're much easier to reach than lower income families. So the politicization of healthcare, I think, is really something that we really need to focus on. But it's also and another important point that I think also talking about Christian principles is the importance of individual responsibility. What does it do to our sense of taking care of ourselves and our families if we say, well, the government's going to take care of that? The government's going to make all those decisions for us. And what does it do to the principle of subsidiarity, which I also talked about at the conference in Rome, where the church teaches that we need to move responsibility and authority to the lowest level possible so that we can have individual responsibility as a key tenet. It's a fundamental tenet of this country. And finally, and I think most importantly, liberty and freedom. When the government is telling us what health care we can or cannot have, under what circumstances, from which doctors, how much we're going to pay or not going to pay, how much in taxes we're going to be paying for these programs, what happens to our freedom? That's really one of the reasons that I founded the Galen Institute, because I believe that the battle for freedom right now, the front, is in the healthcare debate. Because if we lose our control and authority over decisions as personal as healthcare and turn these over to the state, what has happened to our freedom? So first principles, freedom, liberty, individual responsibility, I think are crucial principles that we really need to pay attention to as we think about all of the promises, and I think often false promises, that we hear from candidates about health care. And I want to read to you a little bit from a commentary that Dr. Donald Condit wrote for the Acton Institute last year after this awful film Sicko came out. I was interviewed by John Stossel on a wonderful program he did on 2020 to talk about some of the fallacies of that program. But Don Condit, who's unfortunately out of town and couldn't be here today, I'd really hoped to meet him because we've been corresponding. He said, Pope Benedict XVI wrote in his recent encyclical, Deus Caritas Est, "We do not need a state which regulates and controls everything, but a state which, in accordance with the principles of subsidiarity, generously acknowledges and supports initiatives arriving from the different social forces and combines spontaneity with closeness to those in need." And now that was quoting Pope Benedict. Now Donald Condit says, "We now have unsustainable consumption of medical resources with third world parties responsible for healthcare expenses. A socialized system would increase state dependency and diminish motivations for individual responsibility and charity. Greater government bureaucracy would increase inefficiency and waste compared to doctor-patient interactions. Socialized medicine violates the social justice principle of subsidiarity by interfering with family, churches, charitable clinics, and other intermediate organizations, including the doctor-patient relationship, in attending to those most in need." I certainly could not have said it better or more authoritatively and more concisely, I think, about why the principles that we're talking about here are important in making decisions about health care. And I want to read you, hence my BlackBerry, an email I got just yesterday from a group of doctors who are circulating a petition that I think is really very relevant. For decades, the United States has led the world in healthcare, no question about that. The finest hospitals, medical schools, research, technology, and resources anywhere. Unfortunately, our healthcare system has lost focus to the point where patient well-being is placed after politics, profits, and special interests. Healthcare costs are on the rise, and it's really compromising our ability to, as physicians, deliver the best care. And they have a petition here, and I'd be happy to send it to any of you. Do we have any physicians in the audience? Well, you all have physician friends. So this is something that they're trying to get 60,000 signatures on. It's really a description of what's wrong with our healthcare system from the doctor's perspective. And they're incredibly frustrated with the bureaucracy, both private sector bureaucracy and public sector bureaucracies, in having to attend to paperwork and rules and regulations, oftentimes to keep themselves out of jail, rather than being able to focus on patients. Some of the happiest doctors that I've talked to in a long time are doctors that have completely gotten out of the business of health insurance. They are dealing with private pay. Some of them have something called concierge practices, direct medical practice. Some of them charge a lot, $2,000 a year for all the access to primary care people need and want. Others charge as little as $50 a month. Come see us anytime. We're limiting the number of patients we have in our practice so that we can deliver quality medical care. We are going to be back in the practice of medicine again and get out of the practice of paperwork. So that's really the question, is how are we going to move toward a system that continues to value innovation? When I talk to our colleagues from Europe, they say, please don't do to your healthcare system what we have done to ours. They all wonder where the good, high-paying research jobs have gone in medical care in Europe. Well, they've gone to the United States in some cases, and other places they've vanished because those countries are all deciding to pay basically for yesterday's medicine. It is a huge effort to try to get any new cancer therapies listed on the state prescription drug lists that are eligible. It's extraordinarily difficult to get new kinds of technology introduced because they all cost money. In this country, if you have the choice, if an insurance company has a choice between paying for a $28,000 ulcer surgery or $500 worth of medicines to treat the ulcer, what do they choose? They say, we'll pay for the medicines. Virtually all private health plans in this country pay for pharmaceuticals because they know they're often going to provide better care and better treatment at lower cost than much more invasive and much more expensive surgeries and technologies. So allowing that medical progress to continue is a first principle. Individual responsibility, freedom, the ability to make your own decisions about what kind of health insurance, what kind of health care arrangement you have. I continually get emails from the Samaritan Health Ministry, which is a church, a affiliation of different churches and people affiliated with them, who basically share medical bills. They don't have insurance, but they all have an agreement with each other that if somebody has health care expenses over $300, $500 a year, that they will all pool their resources to pay for those expenses. And they have a large enough pool that they wind up getting their medical bills paid for, and it costs them much less than it would if they had private insurance. That's the kind of thing that is enabled in this multifaceted system that we have. So what do we do about the uninsured? It is the issue in this presidential election. Senator Clinton has said the only way we're going to get to universal coverage and having everybody with health insurance is for the federal government to mandate that we all have to buy health insurance. Only way we're going to get there. Senator Obama says it's not that people don't want health insurance, it's that they can't afford it. So we've got to address costs first. And similarly, Senator McCain says the same thing. He said we cannot start with a mandate. First of all, it's not going to work. And second of all, you got to look at the next level of decisions that people are going to have to make in order to be able to comply with a mandate. And it's the big issue. You've heard of individual mandate. That's the big debate on the Democratic side of the aisle, whether or not the federal government would require everybody in the country to have health insurance. Massachusetts has already done that. Massachusetts has passed a law that if you are a resident in the state of Massachusetts, you have to have health insurance. We therefore know where this is going. The government has to decide what qualifies as acceptable health insurance. Many companies in Massachusetts provide health insurance to their workers, but it doesn't meet the state mandate, so they're out of compliance. So then what do? You have to start fining people or penalizing them. So there are fines for companies if they don't provide health insurance, qualifying health insurance, and fines for individuals. The fine for individuals quadrupled just in the first year. So people now have to pay a fine, and they still don't have health insurance. Now the state has created a big new pool for subsidized health insurance out of some new taxes and some moving around some federal money and some state money. And what's happened, they had 600,000, 550,000 people without health insurance in Massachusetts. Now they have 300,000 people with coverage. But when you look at the numbers, almost all of them are on these new government subsidized programs. Either an expansion of Medicaid, expansion of the state children's health insurance program, or a new publicly subsidized insurance policy for which people have to pay little or nothing. That's where almost all of the growth has come. So when you hear universal coverage, also think that's going to mean a big expansion of government programs. Government that's going to decide what technologies are available, which ones are not. And the fear I have is that the larger the role of government programs in our health sector, the more innovation is going to be constrained, because government doesn't want to pay for innovation. It wants to pay the least it can. It would be perfectly happy if people only wanted generic drugs and never wanted new medicines. But what about people who say, well, you know, those generics just don't work for me? In fact, there was a piece in the Los Angeles Times recently about new chat groups that are starting on the internet of people who are now rebelling against being forced to take generics because they say that it didn't work for me. You know, especially people with depression and anxiety disorders that are very susceptible to different kinds of doses and different kind of dose of medicines. So moving to a government-run, a system in which the government is telling all of us that we have to have health insurance, really takes us down, I think, a very slippery slope. Senator Clinton was asked repeatedly by Tim Russert on Meet the Press recently what she would do to enforce this. If people don't buy health insurance, what are you going to do? How are you going to enforce it? 3 times he had to ask her, and finally she said, well, we might have to garnish their wages. So it's basically a new tax. And for some employers think, well, you know, bad as it is, at least it's not an employer mandate. Wrong. Individual mandate immediately turns into an employer mandate. Every single policy proposal in which individuals are required to have health insurance requires that employers pay. So it's kind of the worst of both worlds. You've got an individual mandate, employer mandate, government making decisions about what kind of health care and health coverage we can or cannot have, and how much will be taxed. And it will be a new tax that will be with just as onerous of penalties as not paying your federal income taxes. But at least now employers, as struggling as they may be with health insurance, have some control over decisions about that coverage. And some of them can't even afford to offer it. But with a government-run program, the government's going to make those decisions. Senator Wyden from Oregon is, and I have a long list of things that are similar about Senator Clinton and Senator Obama's plan. So they disagree on this individual mandate issue, but they disagree on that, but they do agree on a number of other things, like that everybody should pay the same for health insurance. So that means that 22, 23-year-old Tabitha is going to be required to pay the same premium as a 63-year-old pre-retiree with diabetes and multiple chronic illnesses, just out of school, student loans. You know, that may be treating everybody equally, but I'm not sure that young people would think that that was really a fair deal. I think that's actually one of the reasons that young people find Senator Obama's policies much more attractive. Guaranteed issue. all insurers would be forced to sell policies to anybody, no matter whether they show up. This pay or play, the employer mandate, expanding Medicaid, expanding the state children's health insurance program, buying into a new Medicare-like program, Medicare, which, by the way, is $38 trillion in the red. We would create a new program modeled on that so that people would be able to buy into this program. So, what is Senator McCain offering? At Senator McCain's, I'm going to take just one quick little sip of water here, if I may. Senator McCain is talking about moving toward a system in which individuals have more control over their health insurance. So you don't have to lose your health insurance when you lose or change your jobs. He wants people to be able to buy health insurance that they can keep as they move and change jobs from one city or across the country, that they can have health insurance that they own and they keep with them. In order to do that, he would certainly allow people to organize that health insurance through the workplace, but you don't have to get it through the health insurance and through the workplace. And one of the reasons that we have health insurance tied to the workplace in this country is because of a ridiculous tax policy that dates back to World War II, that no one ever thought they were sort of creating the health policy that was going to dictate how people got health insurance for the next 60 years, but nonetheless they did. By Bob Moffat from the Heritage Foundation has a wonderful talk about this. He said that in World War II, we needed workers, we needed people to work in factories, a lot of competition for labor. And employers were under wage and price controls. They couldn't raise wages. So they said, well, could we just offer health insurance as a benefit without having it be considered part of someone's taxable wages? And the Wage and Price Control Board, I think then Milton Friedman and Donald Rumsfeld, others had a role in that, said yes. And that has cascaded through our system to the point now that people just think that we get health insurance at work and don't realize we get a hugely generous tax break for this health insurance. It's worth much more, almost twice as much as the mortgage interest deduction, and people don't even know they get it. $160 billion, $200 billion, depending on which numbers you listen to, in the value of having the value of your health insurance, which is part of your compensation package, not taxed, the federal or the state level. So people don't see it on their wage forms or their W-2 forms. You know, somebody makes $55,000 a year, and they get a $10,000 health insurance policy at work. I, as an employer, and their boss know that person's costing me $65,000 a year. That's their compensation package, plus any other benefits, taxes. But they're not taxed on that $10,000. Only, though, if the employer writes the check for the policy. And so what Senator McCain is saying, we want you to get the same tax break on your own if you write the check. How hard is that? You know, make it equal. Make it, instead of a deduction, exclusion, make it a credit, details of how that works. But just the basic concept that you as an individual should be able to get the same tax benefit for purchasing your own health insurance policy as you get when your employer buys it for you. New kinds of groups would evolve. So you don't have to just be in the individual market. People would be able to affiliate with their churches or with professional associations, even labor unions, to get group rates, trusted entities in their lives to be able to have health insurance. This would dramatically reduce the number of people without health insurance. If we did also, as Senator McCain said, do a better job of chronic care management. Right now in this fee-for-service system where insurers think they're only going to be with us for a year, why do I need to think long-term? There's very little management and help for people who have chronic illnesses and multiple problems, and really being able to do a better job of managing their care. We need to focus on that. We need to pay for value. We've got to stop paying for mistakes, stop paying for the never events, people that have really, completely wrong medication dispensed that winds up causing them many more days in the hospital. And moving toward a system that encourages people to take care of themselves. And there's been a lot of talk about consumer-directed health care, and I'll stop with this and we'll take some questions. A lot of talk about consumer-directed health care. Some of it not favorable, and everybody says, oh, it's a big failure. Just listen to what they're saying. They're saying it's a failure for consumers to be in charge of health care decisions. Who do you think might be thinking that? It's people who think the government ought to be in charge of health care decisions. So consumer-directed healthcare means that you're going to have more authority to make those decisions for yourself. If you and your family want a particular kind of health insurance policy, let's say you decide, I'd rather save money on the premiums and have a higher deductible policy like most of us do with our car insurance. Or, I've got 3 little children, I really want to go to the local HMO because I know the doctors, they know me, it's easy to get appointments. Let people make those decisions, not politicians, and allow that insurance to be portable so that people can make decisions, and then you will see the market respond to us as consumers. We have one little glimmer of evidence of that can even work in public programs. A lot of criticism of the Medicare prescription drug benefit, but the way that they did it is really a way to show us that this can work. Instead of having the government say, here's a list of drugs you can have, and we're going to tell people how much they can be paid for those drugs. They said, no, we're going to allow people to choose among different plans, and they can decide, does this plan provide the routine, the maintenance drugs I need? All the plans have to provide access to 2 drugs in every category, so they knew they got good comprehensive coverage. They drove the price of that program down. The Medicare Part D program is coming in $200 billion under budget. When have you ever heard of that before in a government program? It's because private competition works. People were out there trying to find the policy and the plan with the lowest premium, and the companies were competing to offer the lowest premium in concert with good quality. So when the government passed the legislation, it said this policy is going to cost $37 a month for seniors. Some members wanted to just lock that in and say, no, it can't be more than that, $37. They said, no, let's see what the market does. First year that the average policy was $22 a month for seniors. Because competition works. That's what we need more of in our health sector, to give people more choices and more opportunities and give the market the chance to provide those options and responsibilities so that we can then have the responsibility to make the right choices for ourselves and for our families. Thank you very much, and let's take some questions. Thank you.